Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. I've been a cardiologist for more than 40 years in the Houston area. The focus of this presentation is ACC AHA 2022 guidelines. The year may be a little different. Cardiac amyloidosis. So we are going to look at the effects of amyloid disease on the heart, how it presents, what are the clinical manifestations, and what options do we have to treat these patients. And we're going to follow the guidelines to decide as how to diagnose various forms of amyloidosis and what options are available in terms of clinical management and their prognosis. So let us begin with the feature presentation. Amyloid disease, as you know, is seen mostly in the elderly population in the cardiac field. Only when we see some patients with hypertrophied ventricle with diastolic dysfunction who have symptoms of heart failure, and because of their age we begin to think about alternative diagnosis apart from hypertension, aortic stenosis causing left ventricular hypertrophy. One of the things that we need to keep in mind is cardiac amyloidosis. Cardiac amyloidosis is characterized by infiltration of these protein fibers, amyloid deposits between the myocardial cells, thus increasing the size of the myocardium, but at the same time decreasing the systolic function of the heart and making the heart stiff. As a result, there is a diastolic dysfunction. Along with that, we have a small left ventricular cavity. Some patients may have associated pericardial effusion, and they are prone for cardiac arrhythmias and conduction disturbances. In addition to that, their electrocardiograms show low voltage despite having significant what appears to be a left ventricular hypertrophy, and in some echocardiograms we can see some dense echoes reflecting some high degree of reflection of the sound waves as a result of this amyloid deposit in the myocardium. Especially CMR would be much more useful in identifying these infiltrative diseases much more than the echocardiography. There are different types of amyloidosis. The two main types are the light chain amyloid disease, which predominantly affects the heart, kidney, and liver, whereas the transthyretin amyloid, which is sort of a genetic disorder, it is seen as a familial mutation of the transthyretin, and it affects individuals where their neurological system and connective tissue problems are much more prominent than the cardiac issue. And there is mutated TTR protein. It could be also familial. The TTRwt wild type is seen in elderly patients beyond the age of 65. But if you look at the prognosis of these patients, that is quite startling and disappointing. The light chain amyloid lifespan is like 1 to 3 years. The AA amyloid with the A variant has the best prognosis, whereas the TTRm has the lowest prognosis, whereas the TTATT or wild type has 4 to 6 years prognosis. We talked about the two main types of amyloid disorders, namely the amyloid with light chain and amyloid with TTR mutation. The light amyloid is diagnosed by, it is a serum plasma cell disease. It is predominantly seen in patients with heart, liver, and kidney involvement, and there is one way to find out is to do the serum free light chain ratio along with like a bone marrow biopsy looking at plasma cells. By doing a bone marrow biopsy, looking at the plasma cell cloning and duplication of these abnormal plasma cells which produce these amyloid deposits. In patients with the TTR, it is a genetic disorder. It is characterized by deposition of amyloid in the myocardium, which is easily picked up by the technetium pyrophosphate scan. As a result, the technetium pyrophosphate scan, a resting scan, could be positive. I have an image of that I'll show you in a minute. Whereas in patients with light chain amyloid, the technetium scan may be very mildly positive or grade 1 positivity noted there. In either cases, endomyocardial biopsy or biopsy of the fat tissue might give us a clue as to what we are dealing with in terms of the type of amyloid disease, and based on that we can determine what is the appropriate treatment for these patients. The diagnostic approach for patients with cardiac amyloid is, of course, echocardiography, which may show concentric hypertrophy of the ventricle along with the changes in the morphology of the density of the echoes reflected from the myocardial tissue. And we also have diastolic dysfunction characterized by prominent A waves on mitral inflow pulse Doppler. There is flow reversal in the pulmonary veins, and we also have dilatation of the left atrium because of the diastolic dysfunction of the left ventricle. And the hallmark point in diagnosing amyloid is the cherry on top appearance in the myocardial strain measurements using 2D echocardiography. So if we have all these findings, concentric hypertrophy, diastolic dysfunction, all of this may not be specific to the amyloid disease. What is characteristically specific to the amyloid disease is the cherry on top appearance of the myocardial strain pattern. And here's the pyrophosphate scan, which is strongly positive, which is indicative of the TTR type of amyloid disease. So the reason I'm talking about all these diagnostic tests is because the pathway suggested by the American College of Cardiology and the American Heart Association is based on these preliminary tests and clinical findings, and hence by understanding these preliminary findings, it makes it much more familiar for us to differentiate the various types of amyloid. And here is the cardiac involvement of the amyloid with the deposition of this amyloid protein. Heart is involved in like 76% of the patients, kidneys in 68% of the patients, liver in 8%, and the rest. And it is the amyloid fibrils which are intermingled with the myocardial fibers, thus increasing the bulk, at the same time decreasing both systolic and diastolic functions. Here's the flowchart put out by the American Heart Association as how do we approach a patient with amyloid or a suspected amyloid. Of course, we look for monoclonal light chain antibodies, and if the antibodies are present, we get a hematological consultation. Then these patients undergo like a biopsy of the fat tissue or even a endomyocardial biopsy. And if there is amyloid depositions seen in the heart, then there is the diagnosis of cardiac amyloid. If it is predominantly noted in the plasma cells in the bone marrow, then they go through hematological evaluation and the treatment is based on that. On the other hand, if there is evidence of ATTR amyloid and these patients are evaluated for like TTR genetic mutation, and of course in these patients the technetium pyrophosphate scans will be strongly positive compared to those with light chain amyloid disease. Once we have confirmed the presence of high technetium pyrophosphate uptake along with the amyloid features of the heart, then these patients are referred for like genetic counseling, and based upon the genetic counseling they may be subjected to individual therapy, and one of the drugs that's available for treating these patients is Tafamidis, which can be tried on these patients, which is a class 1 indication. If these patients develop atrial fibrillation, of course, they need to go on anticoagulation regimen based upon their CHAD-VASc score. So this is a very nice flowchart, first telling us how to start thinking about amyloid disease, and then start off with measuring light chains, look for myocardial uptake of technetium pyrophosphate, and based on this get hematological consultation and genetic counseling, and using these techniques we can determine what is the treatment route. And here's a different way of looking at that from a diagnostic perspective. We start off with cardiac biomarkers, echocardiography, then we go for the monoclonal antibodies, technetium pyrophosphate scan, and if needed, we can also do multi-parametric cardiac MR, which will help us to identify these types of depositions in the myocardium. From there, we can see as what we need to do, depending if we are dealing with like AL amyloidosis, appropriate hematological therapy to reduce the plasma cell activity may help to reduce the amount of deposition of amyloid in the cardiac tissue. If it's a genetic disorder, these patients need genetic counseling and appropriate treatment. So ladies and gentlemen, just to summarize some of the things that we need to keep in mind as cardiologists is diuretics and salt restriction would be the main focus of treating patients with diastolic dysfunction, whether it is due to hypertension, aortic stenosis, or hypertrophic cardiomyopathy, or amyloid disease. Because of the stiff ventricle, they develop pulmonary congestion and edema very quickly, so diuretics, salt restriction, and weight management are of paramount importance. Somehow, drugs like digoxin, beta blockers, calcium channel blockers, and vasodilators have adverse effects in patients with amyloid cardiac disease because they don't help to address the basic issue, which is the diastolic dysfunction and maybe fluid overload due to diastolic dysfunction. If some of these patients develop postural hypotension or orthostatic hypotension, they can be treated with midodrine. And of course, if they develop atrial or ventricular arrhythmias, they need to be taken into consideration and treated appropriately to keep the heart rate at the ideal level. And some of these patients may also need intracardiac defibrillators if they have significant ventricular arrhythmias that are life-threatening. The treatment for TTRwt amyloid is, of course, early liver transplantation, and that might help to reduce the amount of amyloid deposition in the various tissues. So the key points are, ladies and gentlemen, amyloid deposits happen in the elderly population most often. There are two types of amyloid, namely AL and TTR type. AL is a hematological disorder, TTR is a genetic disorder, and the overall prognosis in either of these two conditions is moderate to low. Thank you so much for watching this presentation. I am Dr. Nik Nikam, and please do watch. We have a number of presentations on ACC guidelines, and if you want me to pick on a particular topic as far as ACC guidelines are concerned, I'll be happy to do the research, add additional information, and make these most boreas topic as interesting as possible. And please do subscribe to our YouTube channel, and I will see you in the next presentation.